today we are going to talk about a very, very interesting case in the grand round section of a case of monogenic obesity. Now, obesity is something which we see right day in and out, but most cases do not have a genetic etiology. In fact, most of them don't even have an underlying pathological cause. But there are certain disorders in which you can have a lot of genetic component, and that can have significant implications in terms of diagnosis and management. So we'll be illustrating index case which will really highlight about the complexities of assessment and how difficult it may be in terms of evaluation and management from that perspective. So I'll just start off with this initial case which we saw some time ago. This is a 3-year-old girl with rapid weight gain, and what we found in this scenario was that there was height was 84, but the weight was quite significantly elevated to 26 kilograms. There was severe hyperphagia since birth, and this is something which we need to understand, that if you have an early onset syndromic features, especially hyperphagia, that becomes a significant scenario we have to look at. So this was an early onset obesity in which what we are seeing is that there is hyperphagia which was there. Basic workup was all normal. Everything was normal. There was no developmental issue, vision, infections. And normally we say that if a child has a normal growth, puberty, development and eyes, we consider it to be an exogenous or constitutional obesity. But if its onset is too early, we have to think of a possibility, and this child was found to be a leptin deficiency in that regards. Identification of this will have implications in terms of treatment options availability, in terms of pubertal issues, in terms of immunodeficiency issues, which may happen subsequently in that regards. So obesity overall is quite common in the population, around 10 to 15%. 98% of it is exogenous, and genetic causes is definitely less than 1%. Even if we talk about selected individuals in the first 5-year or first 2-year bracket, the prevalence is less. So before 3 years of age with hyperphagia, still 5 to 10% will have genetic cause. So it's not an exceedingly common cause, but if you identify, you have a lot of implications which we need to evaluate and other perspective. Syndromic obesity, of course, is an important chunk. We are not going to discuss about syndromic obesity. We are talking about single gene disorders which do not typically cause any dysmorphism in most scenarios, and it has implications on treatment and prognosis, which we'll discuss about from that regards. All of you can go and have a look at our website, learning.rososociety.in, wherein we have got a lot of e-learning portal, including our YouTube channel, our website, which has got a lot of tools related to pediatric endocrinology, including fellowship and postgraduate courses. We do run grand rounds, PG lecture series and journal clubs frequently, and our publications are there, and the mobile application which can guide on. Latest of it is our obesity interpreter, which will be quite relevant from this perspective, which allows when to think of a genetic cause, and that's been accepted for publication.
Good afternoon, everyone. So I'll start with my case. A 6-month-old girl child presented with increased weight gain, which was noticed by her parents since birth. There was associated excessive hunger, which was also present since birth. Now the history of present.
When you say excessive weight gain, how do you define excessive weight gain in this period?
Sir, during the neonatal phase, there is a weight loss of around 10%. Then after at 10 to 14 days of life, the child gradually tends to gain weight, and around up to 3 months they gain weight around 20-30.
So what is more? When you say excessive weight gain, what is the definition of excessive weight gain?
We should calculate on the basis of weight for height for this child, whether the weight for height is more than 2 standard deviation score according to the WHO standard.
So weight for length will be the criteria to look at, but historically, some rough ball figure. So how much you said they gain in the initial month? How many grams per day? 30 grams per day. So overall, if you say that we expect the birth weight to double by around 5 months. So if you have some crude idea that, okay, within 3 months, the weight has doubled. Often this happens in these sort of cases, you will expect that to be there in that perspective. And excessive hunger, that's a very, very difficult symptom to get it. So how did you get the question?
The parents told that even if the child was fed, the child was initially 5 months for the breastfeeding. Even if the child was fed, she was crying, irritable, demanding, and whenever they are feeding the child, again she become sleeping or something. And so
And
he
the other thing
was
to look at is how frequent is it? Like after that, how long is the child stable? So normally at around 3 months of age, we expect the feedings to be around 3 hourly or at least 3 to 4 hourly in that regards, maybe 6 to 8 feeds a day. But here, if you're having
every
hour, that becomes very, very significant. What else could be indication of hyperphagia at this age? One is demand, continuous cry, not getting full. So if mother's milk is inadequate, despite good production, if the milk is inadequate and they have to resort to formula feeding, that also can be significant, because these are two remarkable symptoms that you are saying. You're saying about excessive weight gain and increased appetite. So that becomes very, very significant from the clinical perspective to decide about from that perspective.
And in that case, sir, also the weight gain will not be there. Matlab, if mother's milk is not adequate,
so they are forced to give top feed.
Okay, then
that will be the scenario to look at in that regards. What is the most common cause of excessive weight gain in the first 6 months?
Ideally, the inadequate calorie intake due to the calorie dense milk intake.
So breastfed babies are more likely to gain more weight, or the formula fed?
Formula fed will be
formula fed are, but there are also clear-cut growth trajectories which suggest that breastfed babies can also gain a lot of weight, and then at 6 months suddenly the weight gain becomes less. So we are not excessively aggressive in the first 6 months unless it's very, very significant. Carry on.
So the parents complained about increased weight gain since birth, which was getting more rapid for the last 3 months. There was excessive hunger, as discussed. The child is demanding, crying, irritable for breastfeeding every hour almost, and even after feeding sometimes he is not sleeping properly. So coming to the history of present illness, there is no history of any feeding difficulty in feeding, any delayed motor milestones, weak cry, or failure to thrive in the early phase. There is no history of any visual abnormality, as child is looking to her parents and smiling, and all the developments are almost normal.
So you have mentioned very nicely about Prader-Willi syndrome. Do you think this is the age at which the weight gain happens in Prader-Willi syndrome?
No, sir.
So that is making it less likely. But hypotonia definitely is part of many other syndromes as well, as you mentioned. That becomes important.
There was no presence of any extra finger in the hands or feet of this child. There was no history of any poor feeding, difficulty during sucking, poor weight gain, sweating during feeding, visual disturbance, and hearing defect present in this child. There is no history of, though not that significant, but no history of any respiratory distress or any hard kind of bony swelling that is present below the skin in this child.
Why respiratory distress?
Some of the case reports of PHP I have seen, they presented in the neonatal period with hypotonia and respiratory failure leading to ventilation. So that's why I mentioned it.
Because of?
Hypotonia, because of the pseudohypoparathyroidism.
Okay.
So that's why I mentioned it here. There is no history of any recurrent diarrhea or hypoglycemic episodes present.
So if you want to look at PHP in the child, it may not be very easy to identify cutaneous calcification because at this age it may not have developed. So which parent would you like to examine?
Mother.
Yes. So even clinically the mother, you can often get the mother has brachymetacarpia, short stature, moon faces, round faces, and cutaneous calcification which can be there. In fact, I had a mother who gave a history that they had removed lumps which were calcium. This history can become relevant.
Moving on to the history of past illness and the treatment history.
So now any other, so this you have largely tried to exclude the causes which are syndrome. Are there any other causes that you're worried about?
A drug intake would be one that would be important in this age group.
What else? So what are the most, in other words, I'm trying to say that what are the common causes that you're thinking of at this moment?
At this moment, the monogenic causes of obesity and the syndromic causes would be the first priority.
Then?
Drug-induced Cushing could be one, drug-induced and also endogenous Cushing.
Okay. Anything else?
PHP will not present like this one.
Something which is causing hyperphagia.
So, inadequately treated NDI.
Inadequately treated
But
NTI
they
will
are
cause
giving
period
much
of
more,
time.
giving much more top fit and gaining rapid weight gain in that
So
setting.
very rarely some form of diabetes insipidus where you are giving lot of formula feed rather than giving water, they can become obese. But anything more common, more important. Anybody who has hyperphagia and obesity, where is the satiety controlled by?
Hypothalamic lesions, sir, any kind
Yes.
of it.
So that will be a very big thing that you have to always worry about. So the main cause of worry would be, okay, you have no syndromic features, whether it is a lesion. That becomes very, very important if you have that. And then you think of a genetic cause from that perspective. Can hypothyroidism present like this?
This kind of significant weight gain will not be present in hypothyroidism.
Okay.
And there will be developmental delays present, obviously.
So you might have to add features of any seizures because otherwise it will be difficult to mention blanking like episodes which can be there. So these will be suggestive of an intracranial one. Then you can ask history of polyuria because that's a surrogate marker of DI, but which may often not be there. But dehydration, polyuria, you should at least document that there is nothing in that regards because I have seen one patient with diabetes insipidus. But that was a 1.5-year-old child who was being fed a lot of formula feed because of his thirst. And that led to obesity in that regard. So that is the scenario. And Cushing syndrome is quite rare, causing that much obesity so early on. If it is Cushing, what are the cause? Such early onset Cushing's?
It should be adrenal carcinoma or something.
Most commonly, adrenal carcinoma is the cause here. Carry on.
There is no past illness of significant illness or NICU, PICU admission. There is no current treatment for weight gain that child is currently receiving. Moving on to the family history, there is no history of family history of obesity in the family or no history of any consanguinity between parents. The development is according to the age for this child. She sits with support within tripod position and speaks the monosyllable words at the age of 6 months. Moving on to the antenatal history according to parents were uneventful. There is no history of any polyhydramnios or less fetal movement. There is the history was.
What does less fetal movement in a child with obesity indicate?
The child was a term child with a birth weight of 3.1 kg and no history of any intensive care admission. There is no drug history, as I've already mentioned.
You talked about lack of hypoglycemia in the neonatal period. What are you looking at?
One said I have taken the history for the PCSK1 deficiency.
Anything else? Any other? Not maybe obesity, difficult to say obesity, but in which the body size is more causing hypoglycemia.
Beckwith Wellman would be one possibility.
That will be an important cause to look at. Overgrowth syndromes.
Yes.
Yeah.
Appetite is increased in this case. Coming to the nutritional history, the child was exclusively breastfed for the last 5 months, followed by complementary feeding and currently on home-based semi-solid diet. The nutritional intake is mostly due to the excessive hunger and there is an attraction to the calorie-dense food in the last follow-up that we get. That sweet things the child prefer more in terms of food preference. So based on my history, the 6-month-old girl child with normal vision, hearing, development and no history of any drug. So the probable etiology, and we have to mention about this, there is no history of any seizure or any intracranial pathology, any eye signs. The probable etiology being monogenic.
Possibility would be a hypothalamic
obesity is also there. Yes.
So what is the cause of hypothalamic obesity? What is the biochemical hallmark of hypothalamic obesity?
How it happens?
Yeah.
So hypothalamus basically controls our satiety actually. There are 2 pathways there. One is.
So what is affected? I'm asking specifically for that one biochemical pathway or the one pathway which is mainly, how do they behave? If you want to compare them to a monogenic obesity, which form of monogenic obesity will they resemble? So what acts on the hypothalamus?
Leptin acts on the hypothalamus.
So leptin they behave like a leptin resistance. So basically hypothalamic obesity is like a leptin resistance equivalent from that perspective.
So on the general examination, the child is alert, conscious and playful. Faces I have described about is round faces depressed nasal bridge is there, and there was downward bending of the angle of the mouth present in this child. Vitals are normal. The skin of the child is a fair complexion child, and hair
Now, fair complexion, you have to be more objective about that compared to the parents.
compared to the parents, actually, sir.
The child is more
bit
fair,
fair
or
looking,
is it because of the diagnosis that you thought of?
Sir, the child is a bit fair complexion in comparison to at least his father, at least. Matlab, I have not seen her mother
But
actually.
the main issue would be that whether it's too significant finding or it is in retrospect. That
I
would be-
think it's the one retrospective findings actually,
Yeah.
sir.
because I think this is something which we need to clarify,
Mm.
that often once you know the diagnosis, then you start looking at things.
Mm.
But maybe on the first clue, we did
That
not
was not-
find anything,
yes.
because that's important, that clinical clues may not be there
Mm.
in these cases.
Here there is no red and depigmented hair
Why did you look for that?
to rule out the POMC defect in this child. And there was no finger abnormality present in this child.
And what is the pattern of POMC defect in terms of hair color? Does it vary with ethnicity?
It can, sir. It depends on the amount of pheomelanin and eumelanin concentration actually. So based from the red hair to brown hair to completely pigmented hair, the full spectrum can be present
So
actually.
it depends upon the ethnicity. So for most of the Indian people, you may not even find hair because the pigmentation is good enough anyways. It will be more relevant from the European or
European
Caucasian, where this red hair thing is reported more. So it's interesting that many of the POMC defects that are reported from outside those countries, they have a normal hair in that regard. So that does not exclude
POMC.
the possibility of a POMC defect. Of course, we'll talk about that a bit later. Yeah.
Yes. Decimal staging is prepivotal in this child. Anthropometry, you can see the weight is +4 standard deviation score at the 6 months of age, and weight for length is +3.5 standard deviation score for this child. I have given a chart how the height and weight has progressed for the last 5 months in our child actually. And right,
This is not progressed too much. If you look at it in the last 5 months, only gained around 2 kgs.
2 kgs, yes.
While earlier she was 12 kg. So there was a much more pronounced weight gain in the first 6 months, then it becomes settled.
And
so what do you think would be the cause?
Because I think from our OPD visit to up to 11 months, he was given a diet which will be less calorie dense, low glycemic index foods are given, and child has been properly monitored whether his weight is gaining properly or not.
So this is quite
Probably-
good that if you look at the weight gain in that 5-month period is not dramatic. Otherwise the trajectory was quite high.
Yes, sir.
And what's the fourth one is head circumference.
The red one is.
The red one.
Red one is.
And that bottom one?
That is the weight for length, sir.
Weight for length. What does it mean?
Weight for length, sir.
So weight for length has to come as a SDS or a percent. It doesn't come like, it's not weight for divided by length. Okay, carry on. So as you said, it's not this thing.
Actually, I just wanted to show you the weight for length was quite similar. Matlab the height
Stable.
gain and weight gain was almost similar. That's why it was not being changed that
So
much.
if we had the SDS, it will be a better.
But yes, it is. So if we see the weight for age for this child, we can see there is a weight gain, but not that significant, as Sir has already mentioned about that. And if we see the weight for length, again, it is more than 97 percentile, but it is taking an upward trajectory here. So systemic examination in this child was absolutely normal. So we moved on to the investigation, and we found that all other investigations, routine investigations for this child was normal, except the thyroid function, in which there was low FT4 level associated with a mildly elevated TSH level in this
So
child.
what do you think, Nimisha, here? So do you think central hypothyroidism can explain the obesity?
Not alone central hypothyroidism.
So it has to be part of some picture.
Hmm.
Let's assume the FT4 was normal and your TSH was 8 or 9. What are you thinking of? Which condition will come to your mind? In a child who has obesity and increased appetite. Mildly elevated TSH with normal FT.
PHP.
Yes, so this will be a TSH resistance. So you may also have the more common finding in pseudo hypoparathyroidism in infancy is high TSH than low calcium. Hypocalcemia is often delayed in that perspective. So that is something. But here you have a very, very low level of FT4 that you are seeing. So of course you will like to confirm it once before you go ahead. But this is quite low from that perspective. And the cortisol level?
Initial point, we didn't do that. We just go on the next we got an impression whether it is a central hypothyroidism or not, and we moved on to the repeat test of FT4 and TSH, and this time also it is a similar kind of result, a low FT4 with a mildly elevated TSH level with a normal cortisol level, ATM cortisol level.
And what does the IGF-1 tell you?
Sir, it was done from outside.
So IGF-1 will have no role here. What are the fallacies of IGF-1 at this age?
It is a nutritional based marker. It is not after 5 years.
So less than 2 years, no role of IGF-1. And why are we looking at IGF-1? When you're saying it is like a central hypothyroidism, you're not thinking of growth hormone deficiency at this age anyhow. And so that's a it's not going to help you also.
That's thinking of ki it could be a part of multiple pituitary hormone deficiency can lead to IGF-1.
IGF-1 is not a good test to do in somebody who at this age. So it is not going to be of help.
So from here, our differential diagnosis are differentiated into two parts. One is the isolated pituitary hypothalamic disorders like hypothalamic tumors or congenital pituitarism versus the syndromic or monogenic obesity with central hypothyroidism that is often seen in cases of Prader-Willi syndrome, Bardet-Biedl syndrome, Alstrom syndrome, and the leptin melanocortical pathway defect like POMC, PCSK1 or leptin receptor defect.
So why does leptin defect cause the central hypothyroidism like we?
So leptin has a role that we know that TSH is mainly regulated by hypothalamic TRH from the paraventricular nucleus. This is the direct pathway from where TSH is regulated. But there is an indirect pathway where leptin also controls this. Leptin directly stimulates TRH, and also leptin in the indirect pathway via NPY agotylated peptide and POMC pathway, they also indirectly control TRH.
What is more common link between leptin and TSH?
Because when the energy levels are high, when the leptin levels are high, we want to burn more energy. That's why TRH is stimulated, and that is why.
Obesity is a classical example of that borderline TSH. This is because of a high leptin. But if you have a leptin resistance, why is the TSH still high? You're seeing your TSH is high.
Probably the leptin is working on the different pathway, so indirect pathway, and then that is
leptin is causing the central hypothyroidism. Maybe the abnormal form of TSH being produced. Whatever TSH is there is not
bioinactive TSH.
So it is central hypothyroidism. It is because leptin is not working. So what it means is that it is not only related to leptin, but it is a distal effect of leptin, because you are saying it's happening in till around POMC PCSK1. Does it happen with MC4 receptor defect?
Not common, sir. Not.
So it is probably proximal to the receptor. So if you look at leptin, leptin acts on POMC, then PCSK converts into that, and then it's going to act on the MSH, MC4 receptor, and then you have the BDNF TRK pathway, which we'll talk about a bit later. Yep.
So there are two differential. So we have two plans in our hand right now. For the obesity purpose, we want to look.
One big possibility is rather than having MPAP, you can say this is a sort of a big non-functional lesion or some other lesion, not just a hypothalamic, but not just the hypothalamic pituitary, but some other lesion which is causing central hypothyroidism, and the lesion is causing hyperphagia.
Yes, sir. So for the organic pathology, we planned for the MRI brain to look for any organic pathology in the brain. And for the monogenic obesity, we are looking for the clinical exome sequencing in this child. So this provisional diagnosis of 6-month-old female child with normal vision, hearing, development, and no history of drug intake, probably etiology being monogenic obesity or hypothalamic obesity with central hypothyroidism. Moving on to the definitive diagnosis, the MRI brain has been done, and it is showing a small size pituitary gland, but the rest of the pituitary gland is normal, though no tumor or anything that compresses the pituitary is present or hypothalamic region is present. The posterior bright spot is well seen in this case.
So size may be a difficult scenario to go ahead. Can you explain smaller size in this case? Is there a way in which, or maybe once you know the diagnosis, you can come back?
size so small because the pathway is not one.
So, what are the major contributors to pituitary size?
The genes,
Cells.
growth hormone, somatotrophs, somatomammotrophs,
Somatolactotrophs are the most common then.
Then as TSH and thyrotrophs, corticotrophs is there, but less amount.
So theoretically, if the stimulus is less, you can have smaller pituitary, but I would not give too much importance to that. It's maybe milder variation.
Yes. So we go on to the genetic report for this child, and the genetic report this time had shown a defect in the POMC gene, which was associated with adrenal insufficiency, early onset obesity, and red hair in children.
So POMC stands for?
Melanocortin.
So what all is being produced by POMC?
There are 4 hormones that is produced, 3 hormones mainly produced. One is MSH that has 3 parts, alpha, beta, and gamma. ACTH is produced from the POMC, and beta endorphins are produced from the.
So what you expect if the POMC is not there?
If POMC is not there, the MSH part, alpha MSH especially, acts on the MC1R receptor that causes the pigmentation part, the hair, skin, the pigmentation part is controlled by that. MC2R receptor, ACTH acts on that, produces cortisol in our body. And MC3 and MC4 both helps in the satiety and overall energy regulation in our body. So if it is not present, so chances of obesity, increased hyperphagia, that are more common in these cases.
And endorphins?
And endorphins are for the pain regulation. Whenever there is pain, endorphin causes decrease in the pain sensation in our body.
So are they known to be more pain increase or decrease? What will happen if there is a problem in POMC?
So that should be hyperalgia. Pain should be increased actually.
So
pain should be increased. Yes.
In which condition you have got decreased pain sensitivity with obesity?
Prader-Willi. So the definitive diagnosis right now, 6 months old child with normal vision, hearing, development with no history of drug intake, etiology being monogenic obesity due to POMC deficiency. But when we explain this case, there are 2 major questions that came in our mind, that why, if it is associated with cortisol deficiency, why the cortisol deficiency is not present in our case. Even the child is right now 11 months age and still cortisol's level are like 350 nanomole per liter. And second part, why central hypothyroidism develop in this case. So as it has been already discussed, that PO melanocortin has several parts, ACTH, alpha MSH, and beta endorphins, and it acts on the MC1, 2, 3, 4 receptor respectively. So this is the triad of POMC deficiency. We have already discussed about it, the adrenal insufficiency, red hair and fair skin, and the early onset obesity due to MC3, MC4 receptor defect. This case has been published in 2021, which has explained about 2 cases of POMC deficiency along with the previous cases of POMC deficiency that has been present in the systematic literature review. They have shown an interesting chart where they told that obesity and adrenal insufficiency among those 22 children were there total. Among those 22 children, the obesity and adrenal insufficiency are present in 100% of the cases. There are few cases of central hypothyroidism is present, almost around 40% cases of. There are few cases of type 1 diabetes, hypogonadism, and growth hormone deficiencies also associated in cases of POMC deficiency. So I'll move one by one. First, the obesity part. We all are aware of this pathway. We all know that in hypothalamus, there are 2 significant pathways. One is a orexigenic pathway, that is appetite stimulating, and one other is the anorexic pathway, that is the POMC CART pathway. So in this case, the POMC CART pathway is not there. So there is excessive hunger, and that leads to increased excessive calorie intake, leading to obesity in our child. Moving on to the next part, that why there is no cortisol deficiency in this case. The probable explanation is the in some case reports, there has been shown that if it is a heterozygous mutation and it is a dose-dependent effect, how much the gene inactive that is present, they may not have extreme obesity, red hair, or sometimes have some normal cortisol secretion. But they have also warned about that the cortisol deficiency may be evolving, and sometimes it may present as late at 9 years of age. That has been case reported.
Who have lower cortisol levels, primary or secondary adrenal insufficiency?
Sir, the lower levels are in the primary.
Why?
Because there are some ACTH independent actions also.
So that is also important. So ACTH is doing what? It's just pushing star inside to increase the production. But maybe even if you have got limited amount of ACTH amount, that may be sufficient to for the adrenals to produce the cortisol as well. So it may happen during stress, during other illnesses, and that may become important. But as you said, it may evolve also over time. So isolated ACTH deficiency, if you look at it, hardly any cases we see of. So what are the causes of isolated ACTH deficiency? Generally, we always look at in terms of GH deficiency. Then only the manifestation becomes important of hypoglycemia. Isolated is known as, in which cases have isolated?
TPIT is one that causes,
like
POMC can cause.
The other defect. So, but they are very, very rare scenarios. They don't usually present with adrenal. They present with other features.
So as our case was also heterozygous, probably we are expecting that, but we have to keep our eyes open regarding the subsequent development of the adrenal insufficiency, as it is very common in this case.
Do you agree with their classification of uncertain significance?
No, probably it has not, the mutation has not been reported yet. That's why it has told uncertain significance. But if we see the pretest probability in this case, this is a complete case of.
This is pretty good. That you have got obesity, early onset hyperphagia, central hypothyroidism. So POMC is a strong possibility.
So the central hypothyroidism part has been already described, and it has been multiple case reports and multiple articles are there why central hypothyroidism occurs in not only the POMC but also the total leptin melanocortin pathway that has been explained. So there are effects of leptin on the directly on the paraventricular nucleus and indirectly by arcuate nucleus, the agouti-related peptide and the MSH pathway.
So ultimately, as you nicely said, if your energy levels are high, you want to burn some calorie. That's why TSH is going to be high. If your leptin is low, you want to become hypothyroid. So if you look at all the malnutrition related cases where leptin is low, you have features suggestive of central hypothyroidism. That sort of a scenario can also happen in that regard. T4 is low, TSH is not elevated. So that sort of a scenario can happen.